All right. Well, we'll go ahead and get started with today's sports ultrasound case series presentation. I have the pleasure of introducing Dr. William Hollabaugh, who completed his medical school at the Medical College of Wisconsin. He then did a general pediatric residency at Vanderbilt University Medical Center, and then this was followed by a 2-year advanced primary care sports medicine fellowship at the Vanderbilt University Medical Center as well too. Will practiced in sports medicine at Vanderbilt for around 2 years before joining Washington University in St. Louis in August 2024, where he currently practices sports medicine with a focus on pediatric as well as adult sports medicine related injuries, non-operative pediatric and adult orthopedics, as well as then a special interest in diagnostic and procedural musculoskeletal ultrasound. And today he's going to be giving us a lecture or presentation on a pediatric distal forearm fracture.
Awesome. All righty. Well, thank you again for having me today. It's an honor to be here, particularly to present with Dr. Schaff moderating. As he mentioned, I trained at Vanderbilt, and he runs the ultrasound curriculum for the Primary Care Sports Medicine Fellowship and does a great job. So it's an honor to be here and be here with him. Today, I'll be talking about pediatric distal forearm fractures. And again, I'm an assistant professor in the Department of Orthopedic Surgery at Washington University in St. Louis, in the divisions of sports medicine and pediatric orthopedics. So I have no disclosures relevant to this presentation, nor will I discuss any unapproved or investigative devices. Our outline will be similar to previous presentations in that we'll go through my case. We'll discuss various scan considerations that are pertinent to the case. We'll talk about the standard dorsal wrist protocol in addition to some optional images. We will cover the images that I took of my patient and then my report, and then we'll cover some teaching points at the end, and then end with hopefully some productive discussion. So for our case today, she was a 10-year-old right-hand dominant female who presented with right distal forearm pain. So a fairly common presentation for those who see the pediatric and adolescent populations. She had fallen from a scooter with Fuchs mechanism, or fallen an outstretched hand mechanism, directly onto her right upper extremity, no head contact or loss of consciousness. She reported acute onset right distal forearm pain, swelling, and limited range of motion. On exam, she had no obvious clinical deformity. She had mild edema of the distal forearm. She had tenderness to palpation of her distal radius in only that location. She had decreased forearm supination greater than pronation, but overall her wrist flexion and extension were grossly intact. And then she was neurovascularly intact overall in her examination. So I started off with AP and lateral forearm x-rays, the AP being on the left, the lateral being on the right. And what you can see is a skeletally immature patient with a transverse buckling of the distal radius metaphysis cortex, although with a break in the volar cortex and minimal apex dorsal angulation. Now, this was read as a non-displaced volar distal radius metaphyseal buckle fracture. But remember, buckle or torus fractures display cortical buckling with an otherwise intact cortex, and are very common in kids because their long bone cortex is softer, yet has a thicker and stronger periosteum. And distal radius fractures are about the most common pediatric fracture, and buckle fractures account for roughly 50% of those. And so I would contend that there's a clear cortical break along the distal radius volar cortex, but it was difficult to decipher if there was also transverse fracture extension across the metaphysis, which would then reclassify this fracture as an incomplete distal radius metaphyseal fracture, or does the fracture extend into the physis, which would then reclassify this fracture as actually a Salter-Harris 2 fracture, which would have implications for management. Now, whenever we consider using ultrasound, I think it's important to have a goal in mind and make sure that it will provide value. And so in the context of a pediatric distal forearm injury, I think there's a couple of uses that ultrasound can certainly have some value. And so you can use ultrasound to further characterize a known fracture, or you could consider using ultrasound to differentiate whether there's no fracture, whether there's a torus or a buckle fracture, or really whether there's a fracture that requires any other different type of management, such as a Salter-Harris 2 fracture, an incomplete or complete distal radius metaphyseal fracture. And then, of course, ultrasound for superficial structures is good, and so it can identify concurrent soft tissue injuries. Transducer selection is also very important. So when thinking about the dorsal wrist scan, I use the high frequency linear array transducer and the high frequency small footprint linear array or hockey stick transducers, because these high frequency transducers allow for resolution with extremely good detail for soft tissue and bony structures of the wrist and the hand. And so I'll alternate between the linear array and the small footprint hockey stick transducer, such that I start with the linear array and then transition to the small footprint to obtain finer detail, particularly when I identify pathology. Patient position is also key for any ultrasound scan. And so doing or evaluating the dorsal wrist, I'll have the patient seated with their elbow in some degree of flexion and then their forearm pronated. And if you want to complete the volar scan, then you'll have them supinate their forearm. Now for the dorsal wrist scan, I think this protocol looks fairly routine compared to other faculty members who have presented in the past, which would include the first extensor compartment through the sixth extensor compartment, the distal radial ulnar joint, the radiocarpal joint, and then the scapholunate joint and associated ligament. However, there are a number of optional and additional structures that you can evaluate and scan depending on the patient's symptoms in examination. So that could include proximal intersection syndrome, distal intersection syndrome, the scaphoid in its volar axis, although this is the dorsal wrist scan, the ulnocarpal joint, the scapholunate joint and associated ligament, and then the lunotriquetral joint and associated ligament, and then dynamic evaluation for instability of each, the extensor carpi ulnaris tendon and associated dynamic evaluation for subluxation, the TFCC, the superficial radial nerve, and the posterior interosseous nerve. Now, the asterisks in this slide represent the additional images that I chose for the patient that I will present. Now, when we think of pediatric musculoskeletal ultrasound, the skeletally immature patient has nuanced findings that can be evaluated with ultrasound, particularly thinking about bony structures that may be growth cartilage and not yet ossified, and then in addition, physes and apophyses. And so knowing the difference between normal appearing growth cartilage, physes and apophyses, and similar appearing structures is critical, because this can allow us to differentiate normal anatomy from pathology. So for example, normal ossified bone or growth cartilage and growth plates will appear homogeneously hypoechoic and anechoic, and will look like a joint effusion or can be confused with a joint effusion, thickened synovium, or a fracture. And so specifically, the patella and the distal femoral epiphysis, when they're not yet fully ossified, can be confused with a suprapatellar effusion, such as in this picture here. And one way to differentiate that is to simply just move the extensor mechanism, and the unossified growth cartilage will move kinetically with the extensor mechanism, where a suprapatellar effusion may not. And then in addition, physes or apophyses can be confused with a fracture. Now, ultrasound has been proposed as an initial diagnostic test for pediatric and adolescent patients with a suspected distal forearm fracture who are neurovascularly intact and have no clinical deformity, with x-rays reserved for an uncertain diagnosis or for features suggestive of a diagnosis needing manipulation, surgery, casting, and/or follow-up. And so ultrasound has been shown to be diagnostically accurate and then non-inferior to x-rays for physical function, patient satisfaction, emergency department length of stay, radiation exposure, and days of school missed. So when evaluating a patient with a presumed fracture of the distal forearm or wrist with ultrasound, authors have proposed a pediatric 6-view ultrasound protocol, including dorsal, volar, and lateral views of the distal radius and ulna, and then views of the contralateral side for comparison, which inherently include the distal radius physes and distal ulna physes. It is worth noting the limitations of evaluating bone with ultrasound, which inherently blocks ultrasound waves, causing posterior acoustic shadowing. But with that said, there are numerous superficial bony findings that can be identified with ultrasound, including cortical buckling or step-offs, periosteal elevation, callus formation, fracture deformity and displacement, and then an overlying supra or subperiosteal hematoma. And so when starting any of the diagnostic scans, I think it's important to always have a home base to orient yourself to the pertinent anatomy. And in the dorsal wrist, it's recommended to begin with Lister's tubercle, which sits between the second and the third extensor compartments, which you can see here in this picture. So moving in the radial direction, you have your first extensor compartment, which includes abductor pollicis longus and extensor pollicis brevis, which here did not display any associated abnormalities. Moving to the second extensor compartment, you have extensor carpi radialis longus and brevis, which in this patient, again, was normal in appearance. Moving now in the ulnar direction to Lister's tubercle, you have your third extensor compartment, which contains extensor pollicis longus. Moving further in that ulnar direction is your fourth extensor compartment, which contains extensor indices and extensor digitorum communis, which were normal in appearance for this patient. Moving to the fifth extensor compartment, you have extensor digiti minimi, which for this patient was again normal in appearance. And then moving to the sixth extensor compartment, you have extensor carpi ulnaris, which was normal in appearance without any evidence of dynamic subluxation greater than 50%. Moving to the distal radial and ulnar joint, or the DRUJ, here I'm looking for a joint effusion, synovial hypertrophy, cortical irregularities, or any instability of the joint itself, which I did not see. Moving to the radiocarpal joint, here I'm looking for a joint effusion, synovial hypertrophy, cortical irregularities, or any evidence of a cyst or mass, because remember, this is a common location for dorsal ganglion cysts. Next, moving to the scapholunate joint and associated ligament. So to find this, I start on Lister's tubercle, and I scan distal and ulnar, which will bring you to the scapholunate joint, where the dorsal scapholunate ligament is present. And so in addition to static evaluation, you can dynamically stress the scapholunate joint under ultrasound, evaluating through making either a fist or moving the wrist in radial and ulnar deviation to further identify tearing and/or any instability of that scapholunate articulation. Next, we'll move on to my optional or supplemental images for this patient. And so while less common in skeletally immature patients, scaphoid fractures certainly do occur and may be radiographically occult like they can be in adult patients. And so ultrasound can certainly help you identify them. And so with the forearm supinated, you can identify the scaphoid in long axis along its volar surface by first identifying the flexor carpi radialis tendon, which is outside of the carpal tunnel, in short axis. And then I transition the transducer to long axis over the flexor carpi radialis tendon. And the underlying area will be the scaphoid again in long axis. And so here I'm looking for any evidence of a cortical irregularity, typically, particularly a cortical step off, and I did not see one in this patient. Next, moving to the ulnocarpal joint, where I'm looking for evidence of an effusion, synovial hypertrophy, or cortical irregularities, which were normal, or which was normal in this patient. Next is the distal ulna and associated physis, which was normal in appearance and should display a hyperechoic contour of the metaphysis, epiphysis, and then an interposed homogeneous either anechoic or hypoechoic physeal cartilage. Now, occasionally with transphyseal fractures or Salter-Harris fractures, there may be an abnormal hyperechoic line within the physis, knowing that Salter-Harris 2 fractures are the most common type of Salter-Harris fracture, that it would likely be coming from the metaphysis, and this could indicate a Salter-Harris type fracture. And then occasionally you'll see a sub or supraperiosteal hematoma associated with that finding. And so here we have the dorsal long axis view of the distal radius of the affected side of the patient. And so remember, authors have proposed the pediatric 6-view ultrasound protocol for presumed wrist fracture of the distal forearm or wrist. And so in this setting, it's important to consider that the transducer obtains an image about the width of a credit card. And so when evaluating bony anatomy, it's critical to fan the ultrasound transducer to identify localized and sometimes subtle bony pathology. But for this patient, when viewing the dorsal surface of the distal radius metaphysis, you can see the normal appearing epiphysis and physis, although there's clear cortical buckling of that dorsal metaphysis cortex. Now, based off of this image and scanning in this location, I was uncertain if there was also transverse fracture extension across the metaphysis as well. So now moving to the volar long axis view of the affected distal radius, you can see a clear step-off deformity, and with fanning of the transducer, I could see what appeared to be a transverse break in the metaphysis with an overlying subperiosteal hematoma and periosteal elevation, although without clear extension into an otherwise normal appearing distal radius physis. Now moving to the unaffected or contralateral distal radius, this is a dorsal long axis view. And here you can see a normal appearing dorsal distal radius metaphysis, physis, and epiphysis without any cortical irregularities or surrounding abnormalities. And then here is the unaffected or contralateral volar long axis view of the distal radius. And what you can see is a normal appearing volar distal radius metaphysis, physis, and part of the epiphysis without any cortical irregularities or surrounding abnormalities. And so that completed the scan for this patient. And so I think it's important to always write up a complete report when you do a diagnostic scan or a complete diagnostic scan. And so this is what my dorsal wrist scan report looks like, which I think is, again, similar to previous presentations in this case presentation series. And so I underlined the abnormal portions of my report, which for the distal radius and physis, the distal radius physis was normal in appearance. The distal radius metaphysis displayed localized dorsal cortical buckling and volar cortical disruption with an overlying subperiosteal hematoma and periosteal elevation with transverse metaphyseal fracture extension, perpendicular to the diaphysis without clear extension into a distal radius physis. And so in conclusion, I diagnosed the patient with a transverse unicortical distal radius metaphyseal fracture with unlikely physeal involvement. Now, briefly to include a comparison case, this is a 12-year-old male with a left wrist pain status post-Fuchs mechanism who was diagnosed based off his radiographs with a left distal radius Salter-Harris 2 fracture. And so in the AP and lateral views, you can clearly see transverse fracture across the distal radius metaphysis with extension across the metaphysis into the physis. And so I think this highlights how ultrasound, based off the pictures on the right, you can see of the dorsal on the top and then the volar cortex, can clearly display signs of a fracture that would not necessarily be consistent with a buccal or torus fracture, although it can be difficult to identify certain characteristics such as physeal involvement for this patient based off his ultrasound due to the inherent limitations of ultrasound and bone. And so for our patient, she was placed in a right short arm cast for 3 weeks. In her follow-up appointment at 3 weeks, I obtained repeat x-rays, which corroborated her ultrasound evaluation. As you can see, that transverse band of sclerosis across her distal radius metaphysis, corroborating the transverse unicortical distal radius metaphyseal fracture diagnosis. And so I transitioned her to a Velcro wrist brace for 3 weeks, only with basketball participation thereafter. And she has since done very well. And so distal radius fractures are among the most common pediatric fractures, and treatment varies depending on fracture type. The most common distal radius fractures include torus or buccal fractures, which are cortical crumpling, which can be uni or bicortical, but have an otherwise intact cortex and are extraphyseal. And then there's metaphyseal transverse fractures, which we considered, if they're unicortical, sometimes depending on the type, can be considered green stick fractures. Now, bicortical often have complete disruption and are extraphyseal. And then there's Salter-Harris 2 fractures, which can be uni or bicortical disruption and involve the metaphysis and the physis. And I think the distinctions are important because the treatment can vary such that for torus or buccal fractures, studies have shown that you can use a Velcro forearm wrist brace without potentially needing follow-up appointments or radiographs, where for Salter-Harris 2 and transverse fractures, it's generally indicated to use a short arm cast with follow-up x-rays and an appointment for those, and then cast removal. And so the distinction between pediatric distal forearm fractures may be subtle, but there are potential uses of ultrasound as either an initial diagnostic screening tool or just simply in another tool in your toolbox of your diagnostic evaluation that may improve your diagnostic accuracy and or alter your management to be more tailored and specific to the patient's specific pathology. And so in the skeletally immature patient who has a suspected isolated distal forearm fracture, who's neurovascularly intact and has no deformity, I think there are a couple of considerations for adding ultrasound to your evaluation, which could include using ultrasound to characterize a known fracture, if there's any uncertainty as the fracture characteristics. And then you could also consider using the 6-view ultrasound protocol in certain settings to differentiate whether there is no fracture, whether there's a torus fracture, or really if there's any other type of fracture that would differentiate the management that you need, different from no fracture or a torus fracture. And so an example where you could do this would be in a resource-limited setting where you maybe don't have x-ray, but you do have a handheld ultrasound device, or on the sideline, if you have a handheld ultrasound device to help with return to play decision-making. And in doing so, you could avoid x-rays, casting, and or follow-up if no fracture or a torus fracture is identified. And so with that, I will wrap up, and I hope it's been helpful to review the diagnostic dorsal wrist ultrasound scan, in addition to learning about how ultrasound can plausibly be applied to pediatric distal forearm injuries and fractures.
Hi, this is Doug Hoffman. Well, that was fantastic. I have a question for you and or Stephen, because I don't see a lot of pediatric fractures, but one of the tough distinctions is a non-displaced Salter-Harris 1 type fracture. Again, so clinically, typically we diagnose those with normal x-ray, but they have pain over the physis. And so we just assume at that point there's a Salter-Harris 1 and treated as such. So if you have an isolated Salter-Harris 1 type fracture, what are some of the ultrasound findings that you see with that would clue in saying, yeah, there isn't a occult fracture, X-ray normal?
Yeah, I think that's a great question. You might not see any findings. I think that's one of the limitations of looking, with ultrasound at bone. But some superficial findings, I think you could see, an associated hematoma, which would then potentially either raise the periosteum, either if it's subperiosteal or potentially supraperiosteal. You could potentially see a widened physis, I think is important to note. And I think that would then be helpful if you looked at the contralateral side. I don't personally know if there's studies looking at any cutoff values for that, but I certainly think if there's asymmetric widening and then there's tenderness palpation directly over the physis, I think if that's localized and those two things are present, you could certainly consider that as your diagnosis.
Do you ever see hyperemia of the physis itself when it's injured? Let's again, a Salter-Harris 1 type fracture.
Personally, I've never looked for that. I'm certain it could be present. I know sometimes more with, chronic tendinopathies, it's certainly present. It takes time to develop, but in the fracture setting, certainly we know there's increased blood flow after a short period of time. And so I'm certain it could be present, but personally, I've not necessarily used that as a tool.
Yeah, I mean, it's kind of the same scenario with the distal fibula, in the skeletal mature athlete and they have an inversion sprain and they're tender over the distal fibular physis. And it'd just be nice to know, okay, early motion versus some protected if there's a Salter-Harris 1 type fracture. So something I think about a lot. Again, I don't see a lot of the pediatric population. So I was just curious your experience.
Sure. And I know there's a good study looking at, the or not ultrasound of MRI and Salter-Harris 1 distal fibular fractures versus, a classic sprain and the findings associated on MRI. So I think you could corroborate those type of findings on ultrasound as well.
Sure, sure. Thanks.
Mhm.
Yeah, I guess my thoughts with those Salter-Harris 1 would be, hey, as well, you had mentioned, you might not have a lot of, I guess, direct, findings, but maybe still some secondary, as you had mentioned, either like a hematoma or maybe like slight effusion, and then obviously just correlating to that's exactly where the patient's, having their pain at. So. Well, listen, just a couple of comments that I was gonna make. I mean, Will, this was an excellent presentation. And, one thing we really try to, stress throughout this ultrasound case series is going to be your protocol. And I think this is one unique one, that for these, fractures, especially in pediatric, most of the time we're thinking, of doing these protocols, by, quadrants or regions. And so obviously for the wrist, you can be thinking about dorsal, volar, radial, and ulnar. But this is going to be definitely one, I think, especially for osseous abnormalities, just because of the three-dimensional nature sometimes of those fractures, that you're going to have to be looking in multiple different planes and not just be set in your rigid, protocol of, oh, I'm only going to look on the dorsal. This is going to probably be one, as you had mentioned, that they had described, in the study, that you're going to have to be going to all these different regions to potentially, evaluate, the bone, in its entirety, just to kind of see those differences for fractures. And so I think that's one that's, really to kind of highlight from this presentation to kind of take away, especially for the protocol for these pediatric fractures, is just remembering not to be, just set rigid and only looking in one quadrant. This is going to be something that you're going to probably have to go to the multiple different quadrants. And then the other thing is, obviously, with the ultrasound, as you had mentioned for these, fractures, is this may not be the end all be all for diagnosing these fractures, but I really think that they can kind of augment not only the physical exam as well as then the X-ray, and as you alluded to, can change early management. So it's one of these that if you have ultrasound, in your clinic at bedside or those portable ultrasound machines, definitely start to use this, kind of to better characterize, these fractures. And in some cases, with the X-ray findings, which may lag behind, the ultrasound can kind of have those early findings, which may change your management, for those patients. And obviously, this presentation, I think, kind of highlights that. So those are kind of the main comments that I have to make. But excellent presentation, Well.
Thank you. Well, thank you again for having me. I really appreciate that as well.
I just had one more comment. This is more pertaining to adult type fractures, but along the same lines as dorsal wrist. So, one of the infrequent complications, but not rare. I mean, I see probably one a year um, is a tear of the flexor pollicis longus or extensor pollicis longus tendon at Lister's tubercle. And Lister's tubercles has different morphologies, and some morphologies are an increased risk of EPL tears and others, and obviously the fracture pattern. And I don't think ultrasound has been fully explored in how how it would be used because distal radius fractures are so common. But again, if certain morphologies are identified of Lister's tubercle, or maybe they're screening for an EPL tendon, again, I think about how this can be utilized, and if you see damage to the EPL, again, to catch it before it ruptures. But anyway, it's a topic that's not been fully explored, but certainly exists, and most of us who do a lot of ultrasound have seen a number of these with distal radius fractures. So again, not quite pediatric, but something to think about with ultrasound would be, the Lister's tubercle and the EPL.
Yeah, you could do a surveillance study and look at the normal anatomy and then name it similar to the acromion and call it the Hoffman classification.
Well, it has been looked at. I mean, and I think someone else named it. So that's good.
I'll have to do
Yeah,
a little
Doug,
bit.
it was yeah, I've definitely had a few of those EPL ruptures. A lot of them come after hardware, especially, and they haven't been as more acute than they are attritional. I actually just had one earlier this year working with one of the orthopedic upper extremity surgeons that he was worried about it as the patient was healing with the fracture because of the degree of it. So he had me take a look at it, and it was interesting, as you had mentioned. There was already concern for, tendinosis and partial tearing. So he already decided then to go ahead and take that to surgery before it kind of completely, ruptured, in that scenario. So I think, as you mentioned, I think there's definitely, high utility that if you have a significant fracture, especially for the adult population, and you're starting to be concerned, that ultrasound can be very valuable for taking a look at those and help with management.
Mm-hmm. Right. Yeah, I agree.
All right. Well, if there's not any other questions, which I'm not seeing in the chat right now, or any other comments, that will go ahead and conclude today's presentation. And then we'll have one more presentation for the faculty, which will be in 2 weeks, which will conclude it before we move on to the fellow presentations then next year. So thanks again, Will, for this.
Yeah, thanks again. Have a nice day.
Very nice, Will.